and just trying to like always question, what the data is showing us. If I know, for example, or at least I assume that, I expect 20% of my patients to experience something, and then when I look at my data, it's 8%, I probably have a healthier patient population than I, should be. So like checking it against like our assumptions or what we expect to see in the data is a nice way to check to see how much is too much, but there's no real like hard line to go through it.
One thing I'll add to that is I agree everything with that Paula said. But one additional thing I'll add is the variables that go in the model should also have a biological plausibility. Do I think that an 80-year-old is going to behave differently than a 20-year-old? And if so, if it's biologically plausible, in my common sense metric it fits, then maybe it should go in the model. Do I think this 20-year-old white person versus a 20-year-old black person versus a 20-year-old Asian person, they are going to behave differently, then maybe that race should go in the model. But if biologically that doesn't make sense, then maybe it shouldn't go in the model.
Go ahead. Okay, sorry. I might ask a question maybe a little bit controversial the other way, which is some people who are deeply into, I'll call it non-modeling AI, generative models, would say that is how you get away from bias. Because bias is occurring by the people who are picking variables, people who are choosing the data sets. So what some of them would say is if you have enough data, I'm not suggesting I ascribe, but this is a constant push-pull in our space. If you have enough data and it's unstructured, doesn't matter. If you have enough data, you have all the world's data as an example, but you have a lot of data from many health systems, and you can truly say what the outcome of interest is. These are people who we've adjudicated had PAD or had a death or had an event we didn't care about. Then using the non-structured modeling of generative groups are saying that, and I've seen papers and I see people saying that's where bias gets reduced because we're not deciding should we be using this variable or that variable. We're just getting so much data that we overcome it. What is your panel's thoughts on that?
I think all data is inherently biased, and so it's not going to solve the problem. I mean, I think by throwing our hands up a little and letting the computer make the decisions a little is a way to almost, I think that's one of the unintentional problems. The example I gave with that company, they didn't decide what variables or what words or what, they were using large language models there, but like what keywords for the algorithm to look at. They just said, here is the data, you find the patterns, and the algorithm still managed to be incredibly biased because the underlying data was. And so I think it makes it a little more black boxy because we don't necessarily check under the hood when we kind of seed some of the decision making. But yeah, I question, you could have all the data in the world, and if it's inherently biased, your results will be inherently biased unless you make active decisions to try to mitigate some of it, in my opinion.
I mean, I just want to echo that, and I think that, even with what we consider to be level 1A, randomized control trial data that we base our practices on, I've never actually thought of a clinical trial as being the fundamental absolute truth. And all of us squabble at meetings about, how can we generalize this? Like, these patients are different than my patients. And so, the point of research is that there's not really one fundamental absolute truth. And to think that with all of the data in the world, a computer can tell us what the absolute truth is in an unbiased fashion is just, aspirational.
I'll add to that what makes us human is our flaws, right? We are flawed. And one of our flaws is that we are biased. I'm always going to like my kids more, even though they could be absolute idiots. I will like them more than, somebody else's kids, right? That's my bias. That's going to be everybody's bias.
My kids are better.
Exactly. Now, I think it's a fantastic question. Can generative AI help against biases? The problem is generative AI is also trained on biased data, right? There are papers out there. There's a very nice paper out of MIT which shows that when generative AI is asked to read notes and come up with recommendations. Its recommendations change based on how the note is written based on patient's race, even though it's told explicitly not to look at race. But anything that we do, the biases creep into that.
I've got one other source. I'm probably the only private practitioner, I think, in the room. Not including private practice in your gathering of statistics, being an ivory tower health system type of resource is a real problem, I believe. That's if there are still private practitioners out there. But my personal sense of responsibility to my patients, especially as a surgeon, where you take a knife up and cut them, you're expected to perform to a certain level. And that was ensured by my own abilities and my own conscience, as well as the people I competed against in private practice, who always made note of your problems. You know, and that's totally missing from any of your evaluation. All of what you're gathering is all treatment, not by individuals, but by systems, by teams. And I think you lose a lot in that translation. That's another source of bias in your data.
I think that's a really excellent point, and one thing that I pointed out, or I was thinking about just in the health system where I have been in the past, like look at rural health systems, they're just trying to they're just trying to survive, and expecting them to have the infrastructure to provide data for researchers, that's really tough. So how can we partner and empower private practitioners to be able to contribute to existing data sets? That's a really important component that we need to think about when we're building our trials and doing these things, so that our results will actually be implemented, because who's going to trust your results if you never gave data, right?
We have time for 2 more questions.
Great panel. As you guys were talking, I was thinking about one of your slides about removing certain types of data from the data set to try to reduce bias. And it dawned on me that I think the AI models or the algorithms will still be able to detect who's of whatever race. Like, you remove it and the algorithm will still find it. And that is borne out more in the computer vision literature, where they applied algorithms to chest x-rays, like cervical C-spine x-rays as well, and found that these models were able to say what race the patient was, just on black and white images. And so I don't think we'll get away from bias necessarily with the variable selections, but maybe we need to think differently about how we're even building our models and what we're asking our models to do. So instead of saying, like, detect PAD in this population of patients, it's find me the disadvantaged African American males who are likely to have PAD versus not have PAD, and ask very specific questions about groups we think are going to be biased against, so that we can develop AI models that work for them, as a thought.
I
Great
think
thought.
that's an excellent point.
I was just going to question a little bit about maintaining being agnostic and not thinking you know too much about bias. When you said, when it doesn't pass the test of whether or not it might be biologically relevant, how do you know that? We know that race, for example, plays a role in hypertension medications. We know that age plays a role in lots of disease processes, and the NIH even makes us include sex as a biological variable in animal studies. So if we go too far the other way, we're really not being agnostic either. So how do you make that general sense of, when it's, quote, biologically plausible to include it or not to include it? Or should we look at it both ways before we make a decision about what's real and what's not real?
That's a fantastic question. I think it depends on the question. And a lot of times, whether something is biologically plausible or not will depend on the content expertise of the people who are helping develop the model. So not the computer scientists, but the clinicians. And what was thought biologically plausible 50 years back is probably not biologically plausible now, and vice versa. So these things, unfortunately, evolve as our understanding about human biology evolves. And maybe some things that we think are biased, maybe they are not biased. Maybe they are what they are supposed to be from a biological sense. So these things, I think, will just evolve with our understanding. So what I think is most helpful is us framing the right questions. What exactly are we trying to understand? So for example, going back to the study by Obermeyer, if the question is we are trying to understand, to develop a model which identifies patients who have higher healthcare needs, then we need to really think, how do we determine higher healthcare needs? If we use cost as a proxy for that, what are the potential downsides that could happen? If we use ER visits, what are the potential downsides that could happen? If we use something else, what are the potential downsides that could happen? And kind of do analysis in different ways and see what best would suit for the model, for this model in the situation we are trying to implement it. There's always going to be some bias.
And just to jump in quickly about race specifically, race is a social construct. So when we're using race, what are we trying to get at? Is it a genetic, we find genetic ancestry and race don't actually correlate all that well, so maybe we should be using genetic markers instead of race. Is it certain environmental exposures, because we know racial ethnic minorities and low-income populations are more likely to have environmental exposures to pollution and all sorts of things. So is it exposure to that we're trying to get at? Is it access issues? Is it health, nutrition? So I think digging into more of like, when I say, oh, this race, because it's not biological in large part, like, what is the biological mechanism that we're trying to get at, and we're using race as a very poor proxy of it. Maybe we should get better measures of what the actual biological mechanism we're trying to get at. And coming from NIMHD, we do have both intramural and extramural people who are trying to focus on teasing out specifically ancestry versus race, as well as, how do we better measure that? Because when we talk about race too, like, who's measuring it? Are you assigning it, is the doctor checking it off? What do we do with multiracial, biracial people? So I really do believe that we really should not be using race in these models. If you think there is some component of that person that is maybe related to their race, I think you should try to use that measure instead of race as a proxy.